Good evening, everyone, and welcome to Pictures and View, Module 3, which is eFAST quality. So, earlier we had completed two modules, which were chest X ray and computed tomography of brain, respectively. Now we are going for the third and the final module of this whole masterclass series. Fine, shall we enter? How many people are excited here? You can react with multiple emojis as you wish. So, in YouTube too, both Zoom and YouTube. Good. Okay. So before getting into the slides per se, I would like to give you some prerequisites and instructions regarding how the class would go. So I think I had given all the say essential paraphernalia which are required for this class. So mainly pen, paper, and the most of the part, I need your curiosity, attention, and a few amount of how to say wit. Yeah. So let's get into it. So this would be a class for about 1.5 to 2 hours, considering I'm taking out all the basics of ultrasounds, followed by eFAST. eFAST, in the sense, is a very, how to say, specific part of ultrasonography, where you're dealing with, essentially dealing with trauma. So to make it a longer and also much more beneficial for the students, I'm covering all the ultrasonography part, all the basics. Yeah, sure, Tanny. Goodbye. Yeah. So others, anyone who wishes to stay with me, please do. It will be much more interactive, I can assure you. So let's dive in. Yeah. So just for the YouTube sake, these are the copyright disclaimer page. Yeah. So these were the posters. So we are entering into module 3, which is eFAST. Yeah. The following are action plans. I basically divide every steps into these uh the question tags. So these are the subheadings which are dealing with basically what and why eFAST, how are we going to deal with eFAST and its application properties and its further subheadings. Great. Yeah. So this is the first screen of our module. So we'll be talking about the principle. Yeah. So are everyone aware of the principles of ultrasonography? Can anyone text it out? Preferably in simple word. The working principle of ultrasonography is just a single effect. This is the hint for you. Okay, Doppler, good try. EM waves, no. Electromagnetic waves are completely different. We are dealing with sound waves. That's why it's ultrasound, right? Yeah. So the main working principle uh, is basic. Yeah, sonar. Thank you. Thank you very much. So sonar was the word I was looking for. So basically, we are going to use something like echolocation. Doppler is derivative of echolocation. Yeah. And so we are dealing with two working principles here. So one is piezoelectric effect and reverse piezoelectric effect. Next is echolocation. And sonar is the instrument, to be more precise. Yeah. So so we'll go into the first step, which is electrical stimulation of piezoelectric crystals. So has everyone seen ultrasound machine in your institution or clinic, whichever? Just react with thumbs up if you have, or thumbs down if you haven't. Okay, great. Assuming that you haven't, so let me show you the picture here, picture in the following slides. So you can imagine something like a magic wand, I would say. So this is what we call a transducer or a probe. So if possible, let me show you the image here. Yeah, you can see here, right? So we have something of an instrument which emits and also receives sound waves. So this is called a transducer or a probe, right? Yeah. So this transducer has something called a piezoelectric crystal. So the most common material used here is lead zirconate titanate. So that's why PZT is a short form for it. So piezoelectric effect, how it happens is if you are applying pressure to this crystal, it it converts into electrical energy and thus produces electrical signals. And vice versa, if we stimulate with electricity, it will also produce sounds in its resonant frequency. In this case, we are getting the frequency in megahertz. Since the electrical stimulations would be pulsatile in this machine, so we will be producing a lot of ultrasound pulses. So can anyone tell what's the hearing frequency and how to differentiate ultrasound from it? What's the cutoff for it? Uh, Fine, moving on. So the normal human frequency hearing frequency is 20 hertz to 20 kilohertz, and ultrasound's cutoff is more than 20 kilohertz. Yeah, that's great, Vinay. So however, for medical purpose, the ultrasound pulses produced by these PZT crystals would go in megahertz. Yeah. So these produced pulses would propagate through the tissues. We have multiple layers of the skin, subcutaneous tissue, muscles, etc. Right? So from this transducer, from this probe, these pulses would move across the tissue. And since there are multiple tissues, let me give you an analogy. So we have learned about in optics, right? We have something called refractive index. So it tells us more about the density of the system, of the medium. So more the density, more the refractive index, more the electromagnetic wave would be influenced by it. Likewise, when it comes to the transverse waves, which is sound waves, we have something called acoustic impedance. Impedance translates to resistance. So more denser the tissue, higher the acoustic impedance. So what happens when there are multiple tissues in a path of the ultrasound pulse? There's a chance that the pulse might enter and get transmitted and get enter into the other medium, or some might get reflected, or some might convert into heat energy, etc. So this is the image depicting here. So some part might get transmitted, some might get reflected. So this reflected beam would be taken up by this transducer. So it produces as well as receives the ultrasound pulses. So as it told earlier, the piezoelectric effect. So this reflected ultrasound pulse would apply pressure on the crystal, thus producing electrical signals, which should again be taken up by this probe and computed. So it also takes up the values of the travel time. That means from the transducer to the wall or the interface between the two media. And with this time, it will also take the intensity of the reflected ultrasound pulse taken up. So the computer would generate the distance as well as the intensity count based between 0 to 1. And finally, we get something of a grayscale image or the values corresponding to it. Yeah. So shall we move on? Is anyone having doubt with the principles? So in simpler terms, it's basically probe is generating pulse. The pulse is traveling through some medium. Since there are multiple resistance across different medium where it's going, so that's the chance that some might get in directly, some might uh, pierce through it, or some might reflect back. This reflected pulses would be taken up by the probe, and it would compute the distance between the probe as well as the interface, thus giving us the value. Fine. So moving on. Yeah. So this is a simple flow chart depicting how the machine works. So this is the transducer or the probe. So it generates the ultrasound pulse. So this is the interface. It has reflected. So it is again receiving it. So these received ultrasound pulses would be converted to electrical signals whose intensity, etc., will be taken up and will be computed by it. So we have another two new terms here, namely gain as well as TCG. So gain, to understand in simplest terms, yeah, let me use this image here. So this is the probe and this is the ultrasound pulse. You can see here. If you look carefully, you can appreciate the arrowhead becoming more smaller as it moves through the media. It's because sound also has some amount of energy. Excuse me, wait a minute. Yeah. So as this probe produces ultrasound pulse and it moves across the medium, through along its path, it loses a lot of energy as it's passing through a lot of materials around it, right? So this might get dissipated in the form of thermal energy, mostly in the form of thermal energy. Yes. So this phenomenon is called attenuation. So more denser the system and longer the path taken by the ultrasound probe, the the attenuation would be more for the ultrasound pulse. So to secure it, what we do is we have something called a gain function. So gain function in simplest terms, it's done to, how to say, reduce the attenuation. It's basically giving higher energy from the probe itself. Let's say we are giving 100, how to say, I don't, I don't wish to use the unit joules here, just some 100 units. Let's imagine. If it's going across this media, this 100 will reduce to 90, 80, 70, and finally there's a chance that when it's tending towards infinity, the energy would become zero. Yeah. So let me move slowly for you to understand it. So let's say we are having 100 units of energy. It's traveling along the media. So as it moves along, it loses a lot of energy, like say 90, 80, 70, etc. And when it tending towards infinity, the energy will become zero. So if at all I have a substance or an organ to be checked in the middle of this media, and my energy is just dying out just before entering through the desired organ, what I would do is I would increase the energy of the ultrasound pulse produced from the probe. Let's say 100 to 200. So there's a chance that the attenuation would still happen. However, there's a higher chance that it will pass through the desired organ and thus I would get the image properly. So that is what we call gain function. So what is TCG here? TCG is time gain compensation. Yeah, so it's actually TGC. There has been mistake in this research paper clipping. Yeah. So TGC is time gain compensation. So yeah, the same concept. As we move across the medium, more the time taken, lesser is the energy of the ultrasound pulse. So I am compensating it by increasing the gain here. Finally, to get a more brighter image so that it loses the energy much slowly. Yeah. So finally, it computes everything, gives us a contrast image, and we will be getting the necessary inputs. Fine. Shall I move on? Yes. Moving on. Yeah. We would come across multiple ultrasonography modes. So these are the documented modes, namely A, which is amplitude mode. So it gives us the value of one-dimensional peaks. So let's assume there's a cyst in between. So since inside cyst, since there is fluid in it, sound will travel much slower when compared to solids. So there will be a peak change. So in a single path, wherever the peaks are higher, that means there is how to say higher amplitude of the pulse that is traveling through. And based on that, we can get to know a simple idea about what is really is in the way of the path, is in the way of the ultrasound probe in a single dimension. This is very uncommon to be used currently. So the most common thing which we are using or which we are much familiar with. So the first image when it comes to our mind when we say ultrasonography is the B mode or the brightness mode. So this gives us a two-dimensional grayscale image. So as you can see in this image, as the ultrasound pulse is traveling through this arbitrary organ, so, at some points it will enter, some would get transmitted. That means it would pierce through the organ, some might get reflected. So based on this, so longer the path, more darker it would be, and thus we'll be getting a uh, image, which we can show here. So this, I have taken an example image. So this is an example image of a liver followed by right kidney. So just a simple information for you here. Finally, we have something called M mode or motion mode. So this is much interesting. So it's more of a complex version of A mode plus B mode. So what it does is it takes a single point. Let me zoom it in for you. Yeah. Are you able to see the ultrasound probe image here? So you can see a single line here. So this is the cross section of the ultrasound image which we are going to use in M mode. So as it says motion mode, it deals with stop motion. So if this is the cross section which we are taking in, so what this machine does in M mode is when I turn on the mode, it takes all the images along this cross section with increasing time. So the image which you are getting here is just this single cross section of image taken in multiple milliseconds and just uh, concatenated into a single 2D image. So what's the use? This is primarily used for checking for any motion, let's say heart valve movement, etc. So that's one of the more common usage here. Or let's say the lungs, we respire, right? So while during respiration, the pleura would also move along with lungs. So if at all I would like to see the movement of the pleura, so there are multiple conditions where we would have absence of movement of pleura. So to differentiate between the physiological state and the pathological state, we can use something called M mode. Got it? Anyone with doubt, please put up in the chat. I am proceeding with the next slide. Good? Yeah. So this is another mode. So we have something called Doppler ultrasonography, Doppler USG, as Bhaskar Sharma already told us about. So there's something called Doppler effect. So Doppler effect basically says that there's a relation between the frequency of a sound wave and the relative movement between the sound producer and sound receiver. Good. So using the Doppler effect principle, we are using something called Doppler mode in ultrasonography. In this, we have other subcategories too, namely color Doppler, power Doppler, and spectral Doppler. So the most common, which many of the UG students would come across in their periods in the clinical postings, is color Doppler. So what it basically does is it tells us how the fluid, especially the blood inside the blood vessels, is moving with respect to the probe placement. So we have the conventional color here, which is uh, blue is for away and red is for towards the probe. So we have the conventional color coding and the mnemonic for it too. So which is bar, blue away and red towards. This should not be confused with arterial to be depicted with red and venous to be depicted with blue. So this is the one of the most common confusions that can be seen across UG students because from since our first year we have been seeing a lot of diagrams depicting the color of arterial blood to be red and venous to be blue, but this is not the case. This is a different convention for ultrasonography. Got it? Yeah. Moving on. So these are the multiple transducers, or here onwards I'm going to use the term probes. So these are the multiple probes which we'll be dealing with when it comes to ultrasonography. Yeah. Namely, this is linear probe, this is curvilinear probe, and this is phased array or echo probe. These two are, excuse me. Yeah. So this is linear probe and curvilinear probe. You can understand it well by its shape here. So the special feature of linear probe is it produces higher frequency ultrasound pulses compared to curvilinear. So which is about in the range of more than 5 megahertz, we could say. So we have high frequency ultrasound pulses. If you recall your physics in your 11th and 12th standard, you would have come across a formula where uh, or the concept. You would have come across the concept where higher the frequency, more would be the resolution. However, the penetration is very less. It's because if you see a sound wave with a higher frequency corresponds to uh, higher frequency corresponds to lower wavelength, keeping sound waves velocity in a medium constant. So lower the wavelength, lower will be the penetration. As soon as the pulse enters through an organ, it would hit along a lot of particles in the tissue because, of course, every material is made up of molecules. So these higher frequency waves means there are more sound waves in a limited amount of time. So these would just get into a material, hit multiple times, and there will be faster attenuation. Hence, before it enters into a deeper structure, the pulse would die off pretty soon. So higher frequency probes would have very less penetration. However, since they are interacting with a lot of particles in the tissue, we would get higher resolution. Got it? And also, since linear probe is producing rectangular probe lines, this is for a schematic illustration. So just by common sense, you can see curvilinear is producing a much more wider field, and this is producing a very limited narrow fields. And hence, when we wish to see superficial structures which are much smaller and harder to see when it comes to since it's covered along with a lot of bones. Let's for the best example, we have lungs. If you want to see lungs, however, it has multiple ribs. So this ribs doesn't allow these ultrasound pulses to enter deeper because as we saw earlier, it has high acoustic impedance because bones are much more denser than other tissues. So in that case, I would use linear probe because I can keep it in between the ribs, which is the intercostal spaces. And also I can see the superficial structures, which are the pleura. So that would be my primary focus here. Okay. So we have another probe here called curvilinear probe. So this is somewhat opposite to the linear probe. It is it has reduced frequency compared to the linear probe. However, it is still a much higher frequency to be considered, meaning like less than 5 megahertz, but more than 2 megahertz. It's in that range. And if you see the structure of it, we are having a much more wider and splayed field of ultrasound pulses. Hence, it can cover a bigger area. So this is much more important when we are dealing with abdominal structures, as we need to cover a bigger space. And since we have dealing with low frequency ultrasound pulses, they have higher wavelength corresponding to it. So it can go much deeper to it as it's interacting much less with the tissues. And therefore, since resolution is since the penetration is more, the resolution is compensated here. And third one, we have phased array, or many people just call it as the echo probe. So echo probe has a special feature, like it has a very narrow and very small probe, the transducer area. So what happens is this would be much more easier to use in case of tiny crooks and crannies. So since we are getting the term here echo, which is echocardiography for short, so heart is completely surrounded by lungs as well as ribs. So it is really hard to see the heart since it before getting towards the heart, it will just the ultrasound pulses would just die off because we have multiple organs completely surrounding and protecting the heart. Hence, we need a smaller window to just peek in, but we need to get a much wider field. That's why we have something called the echo probe. So the working space is pretty small here. However, since the fields are playing, we'll get the complete image of the heart. Getting it? Or is there any doubt? Yeah, let me repeat about the echo probe. So echo probe, we have small working area. So we can use a smaller area in the body to just peek into the system, peek across the lungs and rib cages to see the heart in total. So this in total is taken care by the wide and splayed field of the ultrasound pulses. Got it? Yeah. Moving on. So before getting into the normal and abnormal things, we have something called artifacts. So nothing in this world is completely pristine or perfect. So we will get a lot of errors in doing so. So these are the term. So these features are called artifacts in ultrasonography. So there are multiple artifacts to discuss. The most common ones are one is shadowing, acoustic shadowing. So as I told you earlier, bones, we have bones, right? So bones are much more denser. So we have acoustic impedance to it. So we won't, the ultrasound pulses may not pass through it, and we won't be able to see the structures behind it. So it creates a shadow like thing. I'm able to put hover my cursor over the shadow. Are everyone able to appreciate it? Okay, good. So similarly, we have also air in it. We also have air or fluid filled pockets. Sorry, we also have air filled spaces. Let's say, for example, pneumothorax. So what it happens is, excuse me, I'm getting the disturbance here. Yeah. So we also have air spaces. So as I told earlier, sound travels much faster in solids, however, slower in air. So since there's increased time for the ultrasound pulses to pass through it, there's a high chance that it would attenuate much quicker than passing through semisolids. So it also produces shadows here, as you can see in this image. On the contrary, if we have, let's say, a fluid-filled space, so in fluids, the ultrasound pulses travels a bit faster than air, but slower than solids. So the attenuation is not as much. So the energy of the ultrasound pulses is preserved as it passes through the fluid-filled cavity. Then once it hits this solid interface, so it starts to get reflected more because there's a big difference between the acoustic impedance between the two media. So it would cause increase the field to be much more whiter. The term used to be used here is hyper echoing. So I will discuss about the terms later. So for now, for simple explanation, it becomes more whiter. So it becomes more brighter here because there's a higher difference in the acoustic impedance between the fluid as well as the semisolids. So this is called posterior acoustic enhancement. Further artifacts here are defocusing. Defocusing, there are multiple things. So one of the defocusing example here is lateral cystic shadowing. So this is a cyst filled with fluid. Since this is curved in structure, when the ultrasound probes enters from above, so this is curved in it. So similarly, how light waves react to convex lenses, this would go in multiple directions. So what happens? The ultrasound pulses, which should go to the lateral side of the cyst, would miss it, so thus producing much more darker image. and just omitting it. However, if you see in the posterior aspect or the deeper aspect, this is much more brighter, as I told before, which is posterior acoustic enhancement. So this area, this part is called lateral cystic shadowing, because the ultrasound pulses, which should come from above to below, it is just getting splayed because of the curved nature. So it mostly acts like, how to say, a convex lens for sound waves. Here is another example of an artifact, which is mirroring. So if you see carefully, this is the liver and this is the area of right kidney. And this white line is the diaphragm. However, if you look more carefully, let me zoom it in, you can see this area and this area looks almost similar, as if they are like completely imprinted. So this phenomenon is called mirroring. So this looks very similar to liver tissue. However, this is above the diaphragm, and above the diaphragm, liver won't be present in physiological senses. So why is that happening? It's because the diaphragm surface is much more shinier due to the peritoneum. So what happens? The ultrasound pulses which are traveling across the liver would get hit in the diaphragm, and it would start reflecting a lot rather than transmitting. So this would produce a virtual image behind the diaphragm. Thus, we are getting a liver-like image here. So we can also appreciate a lot of sinusoid-like things. So this is more of a delusional thing. This does not exist. Above diaphragm, we cannot have liver and physiological senses. Yeah. And the final artifact which we'll be discussing today is reverberation. So in reverberation, what happens is, since ultrasound pulses are sound waves in basic senses, if it passes through a medium, if it's getting reflected a lot, the ultrasound pulses are coming from the probe, getting hit from, let's say, one of the surfaces and getting reflected back to the probe. So while they are returning to the probe, they might get reflected again by another surface. So they might start reflecting multiple times. So this would create a false image. In this case, a band-like artifact. So this is called reverberation phenomenon and the artifact caused by it. Okay, moving on. Yeah, so let's go on explaining the topic proper. So FAST and eFAST. Yeah. So FAST full form is focused assessment with sonography for trauma. And E is just extension of it. So this is a very small and more specific entity of when discussing ultrasonography. So this is specifically done in case of trauma and also in cases where a patient comes to the emergency department who is hemodynamically much unstable or after, let's say, shock. So what's the main difference? What are the components of FAST? Let's discuss here. So we have four sites predominantly, which is cardiac, as you can see here depicted by the numbers, cardiac, right upper quadrant, left upper quadrant, pelvic are the four cardinal components of FAST. So we are extending it to the thoracic region to cover the lungs, since they are also one of the most involved organs when it comes to trauma, and much more important since they form one of the organ in the tripod of life, right? Yeah. So this is the basic concept of FAST and eFAST. So let me repeat. FAST is focused assessment with sonography for trauma, done in cases of trauma and also hemodynamic instability whenever presented to the emergency department. It has four cardinal components: cardiac, right upper quadrant, left upper quadrant, pelvis, and we are extending it to thoracic region in case of eFAST. Ideally, this eFAST must be done within minutes, since a patient who is hemodynamically unstable must be stabilized in as soon as possible. So after stabilization, we need to treat him very quickly so that his chances of survival can be increased a lot. Yeah. So why are we doing eFAST? So what is the indication? So the main use of eFAST is to check for free fluid in a space. In all four areas, we have some spaces of where we can accumulate free fluids. In case of cardiac, we have pericardial space. Right upper quadrant, we have our own peritoneal spaces, etc. And so on left upper quadrant. In pelvic region also, we have something called pouch of Douglas, etc., which is also part of the peritoneal recesses. In thoracic cavity, we have pleural space. So all these spaces are can potentially collect free fluids in case of trauma. Let's say trauma or also hemodynamic instability cases, as in effusion, cardiac tamponade. And trauma means we would mostly encounter with blood or chyle, etc. So, hmm. So these are the main indications. The primary indication, as marked in bold here, is hemodynamic instability after trauma. And in case there is unexplained hypotension or shock, which I told earlier, without history of trauma, let's say there's an example is ectopic pregnancy rupture. In that case also, we can do eFAST. And I have used a dictum here, which is it is more useful in blunt trauma rather than penetrating trauma. The main reason is air. As I said earlier, while we are dealing with a lot of artifacts, this air, as I told you before, the sound waves travel much slower in air while compared to fluids and solids. So the attenuation is much more rapid. Hence, we get shadowing. So we won't be able to appreciate the organs better if at all we are dealing with air, which is just above the organs. Let's say in case of pneumothorax. Got it? Moving on. So these are the technical terms which should be used in while we are interpreting ultrasonography images. So first is hypoechoic. So in simpler terms, these are the simpler terms in my right hand side, and these are the technical terms on my left hand side. So hypoechoic, all these terms are relative in nature, first of all. So in hypoechoic, from the surroundings, the organ seems to be less seems to be having less acoustic impedance, and hence it is depicted more darker in case of B mode of ultrasonography. On the contrary, if the organ has more acoustic impedance than the surrounding, it is displayed much more whiter compared to it, and hence we term it as hyperechoic. If the acoustic impedance is of comparable ranges, then we get isoechoic and thus similar colors. And this is a special case, something called anechoic. This is seen in case of air. So in air, the attenuation is pretty rapid, so ultrasound would struggle to pass through air. So it would completely be shown as absolute black when compared to the surroundings. And we also have another term called acoustic window. I'll tell you about in a few minutes. And if at all there are technical terms, those will be explained down the line. Good? Yeah. So like for every modules we discussed, these when it comes to radiology, we have this golden rules to be followed. So let me read out these, which are say what you see, which is do not extrapolate things and do not imaginate things. Imagine things. Sorry for the English. And next is no confirmatory bias. You should not just put up a diagnosis in your head and look for findings which are complying with the diagnosis in your head, because you might miss some things. Since ultrasonography, though it is non-invasive, it has less sensitivity compared to CT and MRI, and hence it needs more expertise, and we need to have a much more sharper eyes to look out for all the possibilities. Third one, imaging is only a diagnostic tool. This is applicable for every radio imaging techniques. So we properly need history, examination, etc. to comply, to guide us throughout the process of diagnosing the condition of the patient. And next we have physicians are physicians, radiologists are radiologists. Like radiologists have a lot more experience when it comes to radio imaging as well as the interpretation of the same. So we must not be a replacement for the radiologist. However, we must equip ourselves with the basic concepts as well as the expertise to get to know about the basic and gross differences to be identified in the radio images, and which is the primary motive of having this masterclass series. Next, we have always feel free to seek help from the experienced. Yes, and this is much more useful when it comes to being undergraduate or an intern. So our PGs would have much more experience as they would have seen a lot of images. So it's always better to seek their help, irrespective of their responses. And finally, believe in yourself. So everything which you are going to see through radio imaging is just going to be present. It's how you interpret it. So if there's any pathological lesion and you just don't believe in yourself and just think this is a normal finding and I'm just being delusional, or if that's the right word, so you might miss the diagnosis, right? So yeah, and for me personally, I would give more emphasis on the first as well as the last rule of the list. Let's go on. So this is the systematic approach which we are going to use today. First is patient position, which is obviously supine position because most of the patients which you'll be dealing with when it comes to eFAST would be trauma patients. So they'll be in the supine positions in the most cases. And if you want to see more clearly, like for example, if you want to see more free fluids in spaces where it is more appreciable, like if a person is completely in supine position, and if he has a little amount of free fluid, which is harder to see in ultrasound, he can be tilted to about 5 degrees along his long axis. This is allowed. Next is probe position. Probe position, probe movements, and sites will be discussed in the further slides. So, before going into every subtopics of the systematic approach, the main steps which should be etched in our mind is these, which is step zero. Before everything you do, first we need to verify the patient. We should not just, let's say, Jack A and there's Jack M. There might be just two different patients. You can't just confuse everyone and change the diagnosis of these people. And they might have different history and clinical findings. So which are necessary to be correlated to radio imaging. You can't just go blind with radio diagnosis. So there's a proverb, right? The eyes can see what the mind knows, or something similar. Yeah. So, and the final step after every part of a radio diagnosis, the final step must be reported to your seniors. Fine. Shall we move on? Okay, moving on. Yeah. So probe position. So by conventionally, when we are using a probe has something called probe orientation marker. So this is the image of a curvilinear probe. We have a light marker, or sometimes it just be an indentation. So this is called a probe orientation marker, which correspond when it comes to the screen of the ultrasound machine, corresponds to the dot or logo, whichever is there. So if at all you are going to see the image, if you can trace back, if you can trace it in imagination, let me try to draw it here. If this is going to be the plane, you can imagine it like this. This is the dot, probe orientation marker, right? You can see here. Are you able to appreciate it? So this probe orientation marker corresponds to the dot or the logo in the ultrasound screen. And this is the plane which the ultrasound pulses should be generated and transmitted. Good? Yeah. So by convention, this probe orientation marker should always be between these two directions, which is right or cephalad. Cephalad means towards the head. So within this 90 degree of range must be the probe orientation marker. So this convention is followed because if at all there has been no convention, then I can just blindly put this orientation marker to the left, let's assume. Then I won't be able to appreciate which direction is my desired organ to be seen through the ultrasound. So if there are two physicians who are just exchanging the probe orientation markers direction, they might get confused between themselves. So it is essential to follow a convention, right? So the only exception which I came across is when we are using the phased array probe, which is the echo probe. Instead of right, the convention follows the left, which is the cardiac side. As the major mass of the heart lies in the left side, the convention change for echocardiography would be left and cephalad between this. Got it? This is, by the way, this is the probe in top view. Okay, moving on. Any doubt, please put up in the chat, both in Zoom as well as YouTube. Yeah. So these are the probe movements. So since the probe would be our magic wand to be used in the ultrasonography, we must know how to handle it and to move across the patient's body. So there are 6 primary probe movements. So first we are just seeing is sliding, which is going to and fro in the direction of cephalad. So this is the head end, this is the leg end, means just going up and down, right? Yeah, this is sliding. Sweeping is going along the short axis. So this, if this is the long axis of the probe, this is the short axis, you're going across the short axis. So this is sweeping, very similar to the sweeping which you do with broom, and hence the name. Moving on, the next two are rocking and fanning. So this rocking is this rocking term is applicable in case of curvilinear probes as well as echo probes because of their curved area, curved transducer area. So in this curved path, as you have seen rocking chairs in your life, right? So it's like fixing the probe on a specific area of the body and just rocking to and fro in order to appreciate the structures which are cephalad as well as caudal to the area. So let me try to annotate here. Let me take a better color. Yeah. So this would be one of the plane. And if you're rocking like this would be one of the plane. So if at all I'm having an organ which needs to be explored. So in this view, I am getting the 3/4, but I want, if at all I want to see this part of the organ, I just rock it so as to appreciate this part of the organ. Got it? Similarly, we have something called fanning. This is complementary to rocking. So we are fixing it at a specific location and we are tilting it in the short axis. Fine. So it is harder to appreciate in 2-dimension screen. So I need your imaginative powers. Yeah. So if at all there's a structure which is coming, let's say the blue, let me mark the nearer area with blue. Fine. This is towards us. So in this case, if I want to appreciate this blue area, I would just fan it towards this blue area in this moment. So I'll be able to appreciate it. If I want to appreciate the farther area, I'll fan it on the opposite end. Got it? Yeah. Moving on. I hope everyone is clear with the probe movements for now. There are other 2 probe movements, which are rotating and compression. Yeah. So in rotating, we have seen all the 2 dimension. If you want to completely change the axis to see, to appreciate the other dimensions of an organ, we can fixate the ultrasound probe over a specific location and rotate it along its probe axis. Got it? This is rotating. And finally, we have compression. If at all we want to see more deeper structure and just slightly increasing the gain, just to how to say prevent how not prevent reduce to reduce attenuation and also appreciate the deeper structures better. So what I will do is I will compress the probe much deeper into the patient's skin. Got it? And also we can change the depth in the ultrasound machine. However, to get much more clarity, instead of just changing the depth basically would increasing the field of view. However, this compression would reduce the attenuation because it shortens the path between the organ and the skin. Hence, we'll be getting clear image. Got it? Okay. So shall we take a break? So let's continue with sites after the break. So when it comes to sites, the indications which you saw many slides ago, right? So the indication for eFAST is to check for free fluids after trauma in variety of spaces. So when it comes to abdomen, we have multiple sites where these fluids can get collected. Since you can imagine, so this we have peritoneum, right? So peritoneum is more of a balloon-like thing. You can imagine it like this. So the organs would just give. This is I imagine it like okay. Imagine the peritoneum like an inflated balloon, and these organs just penetrating into it and just getting covered by the inner layer of the balloon, right? Yeah. So these are the cavities where the fluid might get accumulated. Usually the amount is very, very less, like less than around 5 to 10 ml normally, or much lesser than that. So if at all, due to many diseases or even trauma, etc., blood, chyle, or other fluid substances can get accumulated in these spaces. And also depending on the position of the patient, if it's sitting or if he's in supine position, there are dependent parts where these fluids can just float and just get accumulated in the areas. So these are the spaces which we'll be dealing with, namely right and left subphrenic area, and this is triangular ligament area. And since we would have kidney here, we also would have something called Morrison's pouch here. So in between liver and kidney, and we have paracolic gutters, right and left, and we have pelvic areas. If you see it in sagittal section, we can see these are the areas in the pelvis where the fluid can get accumulated. The most important part here is rectovesical pouch, also called pouch of Douglas. So this rectovesical would be named as rectouterine in case of females, as we have uterus here. Got it? Okay, let's move on. So since we dealt with sites, so these are the steps in doing so. We numbered earlier, right? So let me go to this. Yeah. We saw specific numbers. So this is the sequence which we should follow in our mind. So first heart, then right upper quadrant, left upper quadrant, then pelvis, then thoracic. So if we remember it in the systematic order, we will not miss the spaces which we should cover in eFAST. Yeah, so the first site is cardiac. So the possible probes which can be used here are echo probe or curvilinear probe. There are places where the echo probe won't be available. In that case, curvilinear probe can be used. Since heart is deep, that will be more preferred. Linear probe would just show superficial structures. So, okay, for information, these two images were supposed to synchronize, but they are not. And thus, for the following sites too, my recordings are asynchronous. So please do not try to synchronize the movements of the probe with the images here. Yeah, don't subconsciously do it. So you can see only the images in separate. So this probe movements is just to show how I'm handling the ultrasound probe. Got it? So First of all, we need to apply gel. As I told you, air is a very bad medium for the ultrasound pulses to move. So in order to create a tight seal between skin and the probe, we are adding something called a gel, ultrasound gel. So what this will do is it will form a fluid medium in which the ultrasound pulses can travel easily through the skin. So, and also you can see how I'm holding the ultrasound probe. You can either hold it in the form of a pen or in the form of a TV remote, where thumb would go above and your hand will encircle it, and all your four fingers would come to four other fingers would come to the posterior aspect of the probe. Good. Yeah. And my thumb is actually hiding it. However, are you able to see some black dot here? Okay. This is supposed to be a line, which is our probe orientation marker. So this marker corresponds to this area. So let's see how I am moving the probe here. So this is one of the patient here, keeping the probe, trying to find out where the heart is, just sweeping it down. Okay. And also I'm fanning it. If you saw it, if you see here carefully, I'm fanning here so as to see this part. Sweeping and fanning. Good. You can do all kinds of movement in order to get the best image. Fine. I'm holding it right now to see the heart movements. Yeah. And also currently fanning to see other structures related to it. Yeah. So this is the corresponding ultrasound image which I recorded. Yeah, you can see here. Are you able to appreciate the heart? So this is the heart. So can anyone tell what is this? This area. Can anyone is anyone able to appreciate this area? Can anyone say what organ is this or what structure? In the chats, please. Yeah, take a guess. There's nothing wrong with it. Okay. So the structure which you saw here is the liver. So since we are viewing it in transthoracic view, we have multiple views for heart when it comes to echocardiography. So the view which used in eFAST for the heart is transthoracic view. Sorry, subxiphoid view. Right? So subxiphoid four chamber view. Since we will be able to appreciate all the four chambers. Here. Let me seek it. Able to appreciate all the four chambers can be visualized here. So in this part, we are also getting the left lobe of the liver. So in the earlier technical term slide, I told you a term, something called acoustic window. So here I'm using the liver as an acoustic window. So what does acoustic window mean? The concept is, since I already told you, air travels much faster in objects which are much more denser. So liver is much more denser compared to subcutaneous tissue. So what I'm doing is I'm using the liver substance to pass the ultrasound probes quickly and effectively to the heart. Since heart is filled with blood, so it will eventually attenuate here. And also subcutaneous tissue also has loose tissues. So it already starts to attenuate it. So to preserve the attenuation, I'm using this liver as an acoustic window. So here I'm losing energy. As I go down, I'm losing energy. I'm trying to preserve as much energy as possible. There's still a loss, still a few loss, but it's minimum. And as you go down here, you're able to see the heart clearly. Fine. Because as soon as the probe, as soon as the pulses come here, it got saved by the liver, fortunately. Then it starts hitting and again reflecting back to the probe. Fine. And there are some lines which are possibly due to increased gain or due to reverberation artifacts, etc. So these are just band artifacts. Fine. Let me show you. So the main beauty of ultrasound as compared to the radio diagnostic tools which we used in the earlier modules. All in the previous things, we used images, the static image or a series of static images. In chest X-ray, we just had a single image. In CT, we had multiple images. But still, if you are seeing it at one point of time, you are just visualizing a single image, and then we are scrolling it down to just imagine the 3D structure of the lesion which you are dealing with. However, ultrasound is more real time, and thus it's more for me, at least for me, it is more enjoyable to do it, as you are able to appreciate all the intricate details of the organs in real time in the form of a video here. And then you can freeze it later to analyze or measure, etc. Moving on to the other side, which is right upper quadrant. Here we'll be using curvilinear probe. Fine. You can see the probe movements. Now I'm sliding it, panning, etc., to appreciate the liver as well as the right kidney. You can see how I'm moving the probe. So the location for keeping the probe is in the 10th to 11th intercostal spaces, in the mid-axillary line or slightly posterior to it. Since kidney is a retroperitoneal organ, retroperitoneal means it is just behind the peritoneum. It is just covered by peritoneum only in the anterior side, and it goes slightly other to the posterior wall of abdomen. So in that case, I will keep the probe at the level of 10th to 11th intercostal space in the mid-axillary line. I will slightly pull it posterior till I find liver and right kidney in the same screen, the same plane. Okay, able to see how I'm utilizing the probe. Yeah, and for your information, this indentation is right here. So this is the area where I'm having my probe orientation marker, which is corresponding to this, which means that whatever structure I'm going to see in this side are cephalad, which is towards the head, and this is caudal. And as I move from above to below, it is more deeper, superficial, deep. And this is towards head, towards leg. And if I fan from this area, I'll be able to appreciate all the left and right structures respectively. So as you can see here, so I kept my probe. Now I'm able to see liver as well as right kidney in the same plane. This is much more brighter because I recorded this video in a bright room. Ideally, all the ultrasound procedures should be done in a dark room so as to see the structures clearly. And yeah, so let me pause in the right field for you to imagine. Yeah. So you can see here, this is the liver and this is the right kidney. Since I'm getting both of this in a same plane, that means I'm doing the eFAST examination of the right upper quadrant in the right manner. And this sharp line is the diaphragm, white line. Are you able to see it? There are some sinusoids here. Kidney, this dark area is the renal fat in the hilum. Sorry, fat in the renal hilum. Okay. And this dark area is because we have fluids in the kidney, in the nephrons. Fine. So if you want to see more above, let's say, I am pushing it more above. Now freeze. Though this is the diaphragm, this is the liver. If I see above, this is where the lung tissue would be there. So this area is called the right costophrenic angle. So this is a potential site where the pleural effusion can be appreciated. So if there's fluid collection in the pleural space, we can see a hypoechoic region here. Hypoechoic region just above to the diaphragm. It will be much more darker than the surrounding. Good. Yeah. And there are other things too. We should be dealing with the application part, dealing it in the application part. The next is left upper quadrant. So again, we'll be using the curvilinear probe. So this is the probe orientation marker, the dark line So this probe orientation marker differs with different machines and different brands subsequently. So you can see the probe movement. Now I'm sliding it till I see spleen as well as left kidney in the same plane. So this is where I'm able to appreciate. Since left kidney is superior to the right kidney, we need to go one intercostal space above, which is 9th to 10th intercostal space, and we should also go slightly more posterior. Yeah, because we should also get the spleen. Spleen would slip down more posterior. Fine. Is there any doubt here? Okay, let me repeat again. When compared with the right upper quadrant, left upper quadrant should be examined in the ninth to 10th intercostal space, and it should be in the mid-axillary line, slightly more posterior than what you do in the right upper quadrant, till you get spleen and left kidney in the same plane, in the same screen. Okay. And as you can see here, this is not completely, the probe orientation marker is not completely towards the head. However, as I told you earlier, it is between the right as well as the superior. So I am still following the convention here. This is more comfortable, and I'm able to appreciate the things better in this position. Got it? Yeah. And just another small information, you can see gel here. So the suggestion is use ample amount of jelly so as to reduce the air interface between the probe as well as the skin. Good. Yeah. So let me show you the ultrasound image which I recorded. Yes. So this is the right. Yeah. This is the left kidney. Okay, this image. So this is left kidney, the fat in the renal hilum, and this is the spleen. And if you saw and if you recognize it carefully, the image obtained in the left upper quadrant is very similar to, or I could say, a mirror image of the right upper quadrant. Yeah, and this is the posterior acoustic enhancement caused by the kidney. This is the spleen, and this is left costophrenic angle. Here you can appreciate fluid in case of pleural effusion. Fine, got it? Yeah. And talking about the other structures which we could appreciate, we have something called Morrison's pouch. So in this image, let me show it to you. Morrison's pouch, other name is hepatorenal recess or hepatorenal pouch. So let me show it to you. Yeah. So we are having right kidney and liver. So that's a potential space in between this. So this is called Morrison's pouch or hepatorenal recess. So if at all there is free fluid accumulation in the peritoneal cavity, this might seep and just get accumulated in between here. Okay. And we also have right subphrenic space, which is between diaphragm and the liver. And right paracolic gutter, you need to go more caudally, which is towards the leg. So this is left upper quadrant when it comes to spleen and the left kidney. Yeah. So this is left costophrenic angle, left subphrenic space, and this is spleen, and there is splenorenal recess, potential space again, and left paracolic gutter. You need to go more posteriorly and just lateral to the colon, to the descending colon. Fine. I hope the participants are well aware of the anatomy. appreciate it. If no, you can go to the YouTube recordings again after this session to look out for the peritoneal cavities image as seen in slide number 23. Moving on, this is our fourth uh, component of the for eFAST, which is pelvic region. So here I have not added the probe recording because of maintaining privacy of the patient. However, I have attached the ultrasound screen here. So let me just instruct you. Again, we are using curvilinear probe. This time, okay, please imagine. So right just above the pubic symphysis, we are keeping the curvilinear probe where the orientation marker is towards the right side. Fine. Are you able to imagine? Let me use this image. So if at all we have pubic symphysis here, so my probe would be arranged something like this, just over the pubic symphysis. Got it? And orientation marker is towards the right. So yeah, I hope this image is befitting. So first I am keeping it in that orientation prescribed earlier. So this is the urinary bladder, as you can see. And this is the posterior acoustic enhancement caused by the urinary bladder. Able to appreciate it? So this is my right side as depicted by my orientation marker. This is left side, and this is superficial, this is deep. Now I am fanning it in the cephalocaudal direction. That means into the head to leg direction. So as I am, wait, here. As I am fanning, you can see how the bladder just grows bigger in size and then shrinks. It's because of the cross section of the bladder. Watch carefully. Just notice the change here. Yeah, at this point of time, you can appreciate a gross change as if it's twisting. So what I'm doing is I'm rotating the probe to the probe orientation marker towards the cephalad direction. Now I have completely rotated it and I'm fanning it in the left-right direction. Okay. Because of posterior acoustic enhancement, I'll also increase the gain. I have kept my time gain compensation a bit too high here. That's why I'm getting a much more brighter image, much more hyperechoic area here. And also added by the posterior acoustic enhancement. So ideally, you will see a sharp line here, which would mark the peritoneum. So the urinary bladder followed by rectum would come here, which is much more deeper. Now I am fanning it in the left-right direction. My orientation marker is towards the cephalad. Fine. This is the urinary bladder. Okay. So along with the urinary bladder, we also see something called pouch of Douglas. Pouch of Douglas, other name in men, it is rectovesicular pouch, and women, it is rectouterine pouch. Yeah. So if we have, yeah, if we have if we have rectus here, and there is peritoneal covering like this. Let me go to the schematic diagram for easy understanding. Yeah. This is the rectum and this is the bladder. So this part, this peritoneal covering forms a potential space which is called rectovesicular pouch of Douglas. Rectovesical in case of male and rectouterine because uterus comes in between rectum and bladder here. So it will become rectouterine pouch. And also there's another space to consider in case of females, which is called utrovesicular pouch. So as I told you before, the uterus would come like this. So there's a potential space here. So this space is called utrovesicular pouch. So this will also be covered in case of pelvic examination in eFAST. Fine. Now, moving on. Next and final component of eFAST. So FAST plus the extension of thoracic cavity, eFAST. So we are going to see the pleural movements basically. So that's what we are actually interested in, because let's say what are the most common conditions to be seen in lungs whenever we are going to use ultrasound? Possibly pneumothorax or lung collapse or pleural effusion, etc. In all these cases, and more specifically pneumothorax, the air would just, since air is much more lighter, it would just come and get accumulated in the anterior area. So what happens, as we saw in the artifacts, we get something called acoustic shadowing. So we won't be able to appreciate the lung tissue. So what we have done is in eFAST, we won't even consider the deeper tissues. We are more concerned about the pleural lining, the parietal as well as the visceral pleura. So we are using something called linear probe here. As I discussed earlier in the probe slide, linear probe produces streamlined ultrasound pulses parallel to each other, which are of higher frequencies, more than 5 megahertz. So since they're higher frequency, there is higher resolution with with reduced penetration. So they are complementary to each other, right? So now I'm going to get much more clearer and better images here. However, it is only limited to superficial surface. Yeah, you can see it. First, let me show. Okay, the probe movement. It is just an image actually. So what you need to do is you just need to keep the probe in with the orientation marked in the cephalad direction, just over the third and fourth intercostal space. But intercostal space is necessary because as you can see here, these two are the ribs, and these ribs are producing shadows. So we cannot see the pleura beyond these ribs. So better to keep in between the intercostal space to appreciate this pleura lining better. Got it? Yeah, we need to keep it stationary. And for better view, if at all we need to go to lower intercostal spaces, yes, we can move it down. Fine. Yeah, let me show you the image, corresponding ultrasound screen image here. That's an interesting observation here. Yeah, you can see carefully. One, it is moving a lot. Yeah, there is a probe movement too. However, the pleura is moving corresponding to the, sorry, along with the respiration. Got it? So let me zoom it in and I will tell you a specific finding here. This is of a low resolution because that's what the canvas supporting here. So if you see carefully, yeah, see the pleura again. You can see some white specks or dots just flashing here. This one and this one. Let me annotate. Somewhere here and somewhere here. Also, there was something. Now, as soon as I move, see, you can see this white specks are moving to and fro with respiration. Let me play it again. Yeah. You can see some white specks moving across like this, and now it's getting back. Let me play it again because this is one important finding. Yeah. These dots are moving across this pleura, right? Pleura is the brightest line here, just below the ribs. So this finding is called ants on a log. Ants on a log. Let me just type it. Next. Ants on a log sign. Right? This is a normal sign, completely normal. So which just says that lung sliding is present. So lung sliding can be identified by this sign, ants on a log. So if at all there's no movement of these supposedly ants on a log, so we can just say that the lungs, the parietal, there's no movement between parietal and visceral pleura. They are not sliding over each other. Hence, lung sliding is absent, which is seen in pneumothorax. Since air is getting trapped here, it won't move and slide across each other. Got it? Yeah, I hope there's no doubt here. If at all there's no doubt, please feel free to put it up in the chat box. Yeah. So this is the pleural space. Since there's no fluid or air right now, the parietal pleura and the visceral pleura are opposed to each other. Good. And also we just now saw lung sliding as we saw with the ants on the log side. Next, we are going to see the M mode of the thoracic imaging. Right. So M mode we discussed earlier, right? So it deals with stop motion. Let me move on to it. Yeah. So we are currently picking up. Let me uh, Let me depict the dots here. It might not be quite visible. Okay. So these are the dots as seen on the monitor. So it's forming a cross section line. My line is quite haphazard because I'm using my mouse for it. My apologies. Yeah. So this is the cross section activated on the M mode. So what this M mode does is it now produces a series of one-dimensional images across this cross section in order to form a 2D image, as you can see. At this point, the linear probe must be completely stable over the patient's skin so as to not create crinkles in the M mode image. Able to see here? Good. Yeah. So in this, there's another classic named sign here, which is called sand shore sign. Sorry, seashore sign. So this looks like a beach actually, right? According to the person who named it. This is the plural. So this looks like water, this looks like sand, the shore. So this is seashore sign, which is normal finding. Normal finding in M mode of thoracic ultrasonography. Got it? Let me repeat again. M mode, what it does is it takes series of one-dimensional images across the cross section to form a linear to form a continuous 2D image. So we since in a normal patient, the lungs would in M mode would show something called seashore sign. Okay, which is a normal finding again to emphasize on it. Because we have other named sign too, which I'll be dealing with during the application part. Moving on. Yeah. So clap for yourself. We have reached the application part. So since eFAST is more real time, there are less evidences, less files to share with you from across the internet. There are less open access images. So I've used a few to teach you rather than uh, quizzing on you. Because one, eFAST or ultrasonography in general is much more difficult to grasp and master when compared to chest X-ray and CT, MRI, etc. Because this is more of dynamic. This ultrasonography is more dynamic, and especially in eFAST. eFAST should be done in within minutes. So it is too fast that people usually don't how to say practice a lot in eFAST. More patient you get, the more eFAST procedures you do, the more you get practice. So I felt there is little point in quizzing you. So I kept a lot of images for you to learn all the special conditions and to diagnose for you. Okay. So this is where we are getting the most interactive here. So I want everyone to keep your chats open and help me with finding the images here. So yeah, in application part, I have multiple ultrasonography graphic images here. So your objective is to identify as well as report it as positive or negative. Yeah, we usually report eFAST as eFAST positive in this space in this region. For example, eFAST positive in hepatorenal recess in right upper quadrant region. We can say so. Or we can, if you are saying more specifically Morrison's spots or hepatorenal recess, we can even omit this region part. However, this single statement is not how the ideal report is done. Ultrasonography, like any other radio diagnostic images, you should give the proper dimensions proper areas to the proper surrounding tissue descriptions, etc. So this for the ease for UG students as well as interns, and for also the to maintain the simplicity of this webinar, I'm just keeping it to a single statement, whether eFAST positive in this region or eFAST negative in this region. eFAST negative means there's no free fluid, positive means there is free fluid. Okay. Third one, okay, we must remember all the golden rules, especially the first and the last one, which if you could recall, right? So could anyone type out what are the golden rules? The first and last golden rule? Yeah. So the first and last golden rules are say what you see and believe in yourself, respectively. Okay, did anyone unmute? That's great. I think someone was trying. Good. Let's move on. So yeah, let's learn together about the application part. So this is much faster image. Let me show it to you. I can show it to you 5 times or more on a request. This is the second time. If anyone want a hint or how to see it, this is a fixated image. Just one of the I have froze the ultrasound screen. So this is the clue part if you want to see it. The point where we must concentrate. Let me play it again. Yeah. Okay. This is the whole image which you need to freeze and analyze. Fine. Just anything in your mind, you can just share it in the chat box in Zoom as well as YouTube. Got it? Okay, got with the answers? Okay, let me open it to you. Oh, Vinay, are you trying to say something? Okay, let me continue. So this is the liver and this is the right kidney. So you can ask how to differentiate between liver and spleen. The thing is, it's very hard. That's the easiest description I could say. So, but as a shortcut, what I could say is, if this is the cephalad surface, this is the cephalad area, and this is the leg or tail end. And as you go deeper, if you are able to appreciate this elongation here, this is most likely a liver because liver is much more bigger and longer. So it will also travel more inferiorly. The right lobe would travel more inferiorly. Whereas in spleen, it is much more, uh, it is more wedge shaped. So it is much more shorter on the inferior end. So yeah. So let me freeze it again. Yeah. So this is liver and this is right kidney. This is diaphragm and this is costophrenic angle. And if you see carefully, this liver and costophrenic angle seems isoechoic, possibly because of the mirroring artifact, which I told you earlier, because diaphragm is more shiny, it can form image here, virtual image here. So here it is isoechoic between liver and costophrenic angle. Seems normal here. This is hyperechoic as compared to the liver. Ah, yes, Deepak. Okay, you're marking something here. Are you trying to say it's more hyperechoic? Yeah, you can use the chat. Okay. So if at all you assumed it as hyperechoic, no, it is not. if you see carefully, that area was actually the shadow. It was actually the shadow formed by the rib here. So this is complete normal area. So that's why I used a whole video rather than this. So, and the more, as we learned in the previous slides, the area of concern is the Morrison's pouch. So, which is hepatorenal disease here. I don't see any space here or any hypoechoic or anechoic space here in between liver and right kidney. So they are just tightly adherent to each other or something. Not adherent, just on each other. So I see no space. So this is possibly normal. Hence, it is eFAST negative in the right upper quadrant region. Yeah. So this is the right upper quadrant region was normal, and hence eFAST was negative in the right upper quadrant region. This is another image. Mind you, this is not an eFAST image, but I just wanted to give you a concept here. So this is not an eFAST image. So in eFAST, we do sub-xiphoid four-chamber view. However, this is parasternal, I presume, parasternal four-chamber. So that's why the orientation is like this. The marker is towards here. Yeah. Are you able to see the marker? This GE something. This is the orientation marker. So it's like this. Let me play it again. Let me freeze this. This is the area of concern. Okay. Here, as we can see clearly, these are the chambers of heart. However, if we go outside of it, go more peripherally, you can see more hypoechoic areas here and here, right? So these are spaces where you have got accumulated a lot of fluid. So this is the case of pericardial effusion. Fine. Pericardial effusion. So this patient might come to the emergency department with Beck's triad, like increased JVP would be there. Excuse me. That's on. Yeah, I'm audible now. Okay, got it. Yeah. So in this case, if the patient is coming to you, he would be mostly an adult who is presenting you with the classic Beck's triad of cardiac tamponade, which is, can anyone type it out? Yeah. So the Beck's triad has low blood pressure, muffled heart sounds, and raised JVP. But JVP is jugular venous pressure. Right? So which would present as distended veins. So let me move on. Let's check whether it's right. Yeah. So there is fluid in pericardial space. So eFAST was positive in the cardiac region. Or we can say eFAST is positive in pericardial space, suggesting of pericardial effusion. So need to correlate with the history and examination. Fine. Moving on. This is another image which you see here. Okay. This is a subxiphoid view. Subxiphoid view. Much shorter video indeed. Again, let me play it again. Yeah, I'm freezing it here. So these are the four chambers: ventricles, atrium, and since I told subxiphoid, can anyone guess what is this solid area? Yes, that is the liver. So yes, absolutely. So this is the liver here. So we are using the liver as an acoustic window to see the heart clearly. So now I'm seeing the movement of the valves seems to be normal, but that's not the aim of the eFAST, right? So in eFAST, we are primarily just rushing up in time, racing with time to see for any free fluids. So the potential space here is the pericardial space. If you see here, this is just a wait. Let me show the atria and ventricles. Okay, good. So these are the ventricles. Fine. Left ventricle, right atria, and left atria. Fine. Any other doubt? Is the doubt cleared, Deepak? Okay, let me repeat again. This is the left side, this is right side. Right ventricle, right atrium, left ventricle. This is the liver. Now here we are having posterior acoustic enhancement, and this is the pericardial space, the potential space here. However, I see no hypoechoic areas in between. Yeah, okay, got it. I see no hypoechoic areas here, and everything seems to be normal. So if you do a lot of practice with the ultrasound in among normal volunteers or in other health or with patients with other pathologies other than the involved areas, you will get a lot of exposure regarding which is the density you would expect. So even if you're increasing the gain overall or increasing the gain in particular layers of the ultrasound images, still you would need a lot of practice to just differentiate between the acoustic impedances, right? So here I'm able to appreciate liver and some sinusoids I can see here. This is the potential pericardial space, right? You can see a dark line. Let me annotate it. So this is the dark line. I marked it with yellow. So this is the pericardial space. Pericardial space has minimal amount. It's not like completely 0 ml. It has minimal amount of fluid. And hence you can appreciate the two layers of the pericardium. Fine. Now, so since nothing seems to be abnormal here, I might report it as eFAST negative in the cardiac region. So let's check it. Yes. So this is eFAST negative in cardiac region. Okay, mind you, this is not the ideal way of reporting it. In eFAST, you just say to your report it is senior as soon as you just do it simultaneously. Like you're rapidly loading within seconds, you're completing all the components of eFAST, all the regions. So as soon as you see it, you just see for the free fluids and simultaneously report it, or at the end of whole eFAST. This is in case of emergency situation. If you're doing something like OSCE, if you're doing like PLAB exam, etc., after completing all the eFAST, all the regions of eFAST, you will be reporting that eFAST negative in all 5 regions. Fine. Let's move on. So again, this is the new image here. This is a beautiful image. I think I took it from Radiopedia or something. Yeah. Let me play it again. Yeah. So this would be my preferred uh, frozen frozen part of the ultrasound video, right? If at all I am freezing the ultrasound video, this is where I would freeze it. So can anyone say what they are able to appreciate here? If possible, you can even annotate. Please choose blue color. Okay. Let me use yellow and red for myself. Please use blue color to annotate if at all you see something abnormal. Or you can type it in the chat box too. Okay. Shadowing. Okay. Shadowing is an artifact can be present because of ribs. Anything much more concerning. Since what's the main how to say use of eFAST to check for free fluids, right? So that must be your primary to search for free fluids. Since we are in the right upper quadrant region, as we can see liver and right kidney here, so we need to check for all the potential peritoneal recesses for free fluid. Are you able to appreciate somewhere? Yeah. So let me reveal to you. So since I told you this is the liver and this is the right kidney, you can see here, like, let me put a star mark or something, this space. Here we are getting hypoechoic area, right? This is complete acoustic shadowing, leave that. So here we are getting some blackish area. So since this is liver and this is kidney or renal, so what is this? Hepatorenal recess, which is Morrison's pouch. So we are getting fluid in the Morrison's pouch. So that's our finding. So at the end of the eFAST, we need to report it, right? So this is eFAST positive for free fluid in the right upper quadrant region in the Morrison's pouch. Yeah. So we got it right. So this is fluid in the Morrison's pouch. eFAST was positive in the right upper quadrant region. Yeah, this is another thing which I like to teach you. This is much more beautiful one. So this is one of the classic signs which you would find out. And by the way, this Samsung written here, right? This is the probe orientation marker. So you can first identify the region. Okay, another information I would like to give it to you. So initially in chest X-ray classes and CT classes, we were telling like we need to identify the site, etc. Right? So here there's nothing like that in ultrasound because this whole thing is a real-time procedure as well as a faster procedure. So I don't think uh, nobody would how to say ask you a question. Nobody would quiz you on the identifying the site of the area because ultimately you need a probe to even figure out and orient yourself. Good. Without ultrasound probes orientation, you can just figure it out. However, I can share it to you that this is right upper quadrant area. Yeah, revealed. So for information, this is the liver. Kidney is somewhere here outside of the probe's view. This is the diaphragm. Okay. It's not like I am helping you. Here in this case, I should help you with the orientation because I know the how the ultrasound probe has been kept, has been placed. So any idea? Suggestions, answers in the chat, please. Good. Okay, let me explain it myself. So this is the liver. Oh, we are getting answer. Fluid in subphrenic. Okay, not subphrenic. This is the diaphragm, right? So we are having hyperechoic region above the diaphragm. That is not subphrenic. It is supraphrenic, or to be more in technical terms, it is costodiaphragmatic space or costodiaphragmatic recess, right? We are getting the angle here. A costodiaphragmatic angle is seen here. So we are having fluid here. This is the liver. This is the liver. This is possibly the lung tissues. And this is not my concern. Main concern is this one. So if you see carefully, I'm able to do a demarcation of like this, right? And if you are more imaginative, I can just split it. So what structure really passes deep to the thorax, which you can appreciate in this shape classically? Hmm? Any ideas? Just make your guess. Be intuitive. So we are getting some structure, hyperechoic structure, in the shape of this serrated ends. Not serrated, corrugated, I will use. Yeah. So let me reveal it. So this is vertebral bodies, thoracic vertebrae, right? These are actually thoracic vertebrae. So in normal cases, you won't be able to appreciate thoracic vertebra clearly because it's much more deeper. The probe, the ultrasound pulses must move through all the pleural, lung tissue, etc., to even try to reach here. However, I'm able to appreciate the complete thoracic vertebra, the spinous processes, right? So, what could be the reason? Anyone make a guess? So, the hint here is artifact. One of the artifacts is helping us visualize this thoracic vertebra. Since it's also brighter, we discussed only one artifact where we are dealing with hyperechoic or brighter image. Just reverberation. No, the artifact which we discussed here was post. Yeah, PA exactly. So posterior acoustic enhancement. So for posterior acoustic enhancement to happen, what the ultrasound probe, ultrasound pulses must do? It must have high energy to even touch it, right? So for that, the medium in which it should travel must be fluid, right? In air, it would just rapidly lose its energy. It might attenuate much faster. In fluid, yeah, comparatively faster and less attenuation, I would agree. So we are having posterior acoustic enhancement. So it denotes that we are having some kind of fluid just superficial to the structure which we are seeing here. So just superficial or over or anterior to in anatomical senses, we are having some kind of fluid here. Let me clear it. So we are having some kind of fluid in this area. Fluid. FPL is fluid for here. Sorry for my handwriting. So we can just say that there's fluid in between. This is the lung tissue, right? I told you earlier. Lung tissue, and this is the pleura. So what is this? This is a pleural effusion, right? So appreciation of this thoracic vertebrae in cases of pleural effusion is called thoracic spine sign. This is called thoracic spine sign seen in pleural effusion. I should do a fact check regarding this also seen in pneumothorax or not. In some sources, it's given pneumothorax. In pneumothorax too, you can see thoracic spine sign, which makes sense. But also, there are other resources that are denying the fact. So, but clearly, thoracic spine sign is a classic of pleural effusion. That's for sure. Fine. Let's move to the other example. Oh, this is one of the other beautiful thing which I observed. Okay. This is, yeah. So first tell me whether it's normal or abnormal. This could be abnormal, this could be normal, right? So while discussing, yeah. So it has been annotated here. This is right kidney, this is left kidney. Their dimensions have been kept here. Fine. So this right kidney, here we are renal capsule, you can see this the kidney nephrons are here, renal hilum, you can appreciate it. Yeah. So here some hypoechoic or anechoic regions are seen. Here also you can see, but this is complete. This can look completely normal because we also have a lot of fats around. This is hip region, right? Sorry, this is flank region, right? So we have a lot of fats around. So these are deeper structures. So we have muscles, etc. So is left kidney. However, if at all, I would say this is completely abnormal. But if you are seeing it, if you are how to say, if you don't have history or examination findings, or if you have less experience to pick it up, which of course even I do have less experience in ultrasonography, the radiologist would have much of sharper eyes. But because of the literature which I read through it, I'm able to see it. And again, which they say, right, the eyes can see what the mind knows. So let me demarcate it here. If you see carefully, I'm able to see like this part, right? This is more hyperechoic. So as we discussed earlier, okay, there are a lot of propagation of these pulses. Still, I'm able to see something. Yeah, these are just this one, probe ultrasound pulses. However, we did not see much of the hyperechoic regions in kidney, and also it doesn't even make sense, right? So if something, let's say the ultrasound probe is going like this, it's hitting the fluid here, which is water, urine, and if it's making the and since this fat is also much more denser, has higher acoustic impedance, this can become hyperechoic. Yes, I agree to it. However, we did not appreciate this much hyperechogenicity deep to the kidney in any of the images earlier. So this is an artifact actually. So what is this artifact? We saw it earlier, just about 2 slides ago or something. This again is PAE, which is posterior acoustic enhancement, which signifies that since we are having enhancement, acoustic enhancement here, so how to say whether this is acoustic enhancement or something? So again, the main answer is you need more experience to it. And also, this is what I learned intuitively here. One of the things which I saw while I was doing ultrasonography, my patients, yeah. So if you see here, are you able to appreciate this transverse lines? I was able to clearly see it when I had gel over the probe. So when there was no gel over the probe, the probe was just directly in contact with the air. So it was completely dark, anechoic. However, when I added gel to it, it somehow showed this lines, transverse lines. Then I kind of imagined, or you could say, that fluids would just reveal more of this transverse waves. Again, sound wave is a transverse wave, so it's getting revealed due to this fluids. Yeah, so yeah. So here also I'm able to see the clearer transverse uh, sound waves. So which means that I have fluid. I am dealing with fluid in around here. Posterior acoustic enhancement, secondary to some fluid collection around the kidney. So yeah, again, since we are watching kidney here, this is right upper quadrant and left upper quadrant respectively. These are the probe markers. So the answer, let me reveal it. So there is fluid in the right upper quadrant and left upper quadrant. This is eFAST false negative. Yeah, as I told you earlier, unlike chest X-ray, CT, MRI, which we are dealing with in hi-fi stuffs, ultrasound, though it's non-invasive, it has less sensitivity and specificity compared to CT. So there are we are more likely to get false negatives and false positives. False positive, for example, if someone is much more obese, so you might think that his whole adipose tissue might be interpreted wrongly, like this one, as free fluid. Or if someone is having subcutaneous emphysema, which is air stuck in between his subcutaneous tissues. So in that case, we can get eFAST false positive. However, in this case, we are actually having free fluid, but it seems somehow normal. So we are more likely to report it normal, unfortunately, by mistake. So we might end up with eFAST false negative. In this case, if someone is hemodynamically unstable and we are getting eFAST negative, so we don't know whether it's true or false. However, if someone is unstable, it's not improving a lot with the interventions going on side by side. However, his eFAST is negative. What we need to do is we need to advance him to CT. This is according to the American guidelines, which I saw in the literatures which I read. Yeah. So if a hemodynamic instability, eFAST is positive, then we can explore in the peritoneal cavity, look for the free fluid, and then relieve the symptoms and also replenish the fluids. However, when we are dealing with hemodynamically unstable person, who's having negative eFAST. Then, along with fluid replenishment and his vital stabilization, we should also order for CT to check for to get much more clearer images with higher sensitivity and higher specificity for free fluids. So, if you are using contrast and if there's any blood leaking into the peritoneal cavity, we can easily appreciate it. Fine. Let's move on to another one. Yeah, this is quite hard to find, but yeah. Okay, just by seeing and with the normal images which we discussed before, we can say that this is a urinary bladder. Yeah, this is the pelvic examination in the eFAST, the fourth component. So this is oriented. The orientation marker is towards the cephalad direction, towards the head direction, and this is superficial. This is deep. This is urinary bladder. So here there must be rectum here. Since the rectum would also have air in it, we can very well get shadowing. Yeah. However, okay, let me help you with this. So the main purpose is not to quiz you, but the main purpose is to teach you. Okay, let me have some water. Sorry for it. Yeah, so the main motive for me is not to just quiz you, but to teach you. So let me freeze it in the desired position. Yeah. If I see carefully, I'm able to appreciate this area. Actually, in actual sense, this is this one, this complete one. However, if I'm a noob, if I'm a beginner, I would just say this part. So also okay, fine. So this is the actual part. So we're able to see something here. This is not completely anechoic, but hypoechoic. Fine. So this area is hyperechoic compared to this one, to the fluid, to the urine here. However, this is much more hypoechoic compared to the walls. This is this one, lateral cystic shadowing, which we saw as an artifact. This is posterior acoustic enhancement in here. So for easy purpose, yeah. So this is where we are having fluid right now. So in pelvic examination, between rectum and between bladder is called vesicle. So I got something here. This is a male patient, by the way. Yes, we are not able to appreciate any uterus here. So this is a male patient. So rectum and vesicle. So we are getting something here. So this is the rectovesical pouch of Douglas, right? Pouch. This is pouch of Douglas. Right? And also another thing which I would like to add. So just because you're not able to see uterus, you should not just say this is possibly a male. So the main thing which would help here is your history and the details which I told. The step zero of radio diagnosis. So, but just since I saw this literature, since I saw the literature, yeah, I am confident that this is a male patient. So this is rectum, this is vesicle, the urinary bladder. These two are artifacts, posterior acoustic enhancement and lateral cystic shadowing. Here we are having some fluid collection, free fluid in the pouch of Douglas. Got it? So let's see whether we are right or not. Oh, yeah. So we have fluid in pelvis. So eFAST positive in pelvic region. Fine. Going on. I think this is probably the last slide. Okay, let's move on with it. What's time? Okay, 9:30. Yeah. I will wrap up pretty soon. Please stay with me. Yeah. So this is the lungs field. You can see the small diagram here, right? This is for a ease. So this is the right lung. This is the left lung. See, I taken in M mode. Okay. Yeah. So what you can see here. Okay, fine. So because of time constraints, let me go with the explanations. So this area, we are able to see a lot of this small speckles, right? Um, we are able to see a lot of speckles here, and we are able to see some straight lines, some straight wavy lines here, slightly wavy. So this is the seashore sign, fine. And also, if you see here, okay, we cannot appreciate much in this region because M mode is all about motion. So better to ignore this part. In M mode, here you are seeing lot of dotted like structures like a sand, and here we are seeing some beach water kind of thing. So this is seashore sign seen in normal lung. So this is right lung is normal. However, when it comes to left lung, I am not able to appreciate the sand-like texture. So this is more of jagged. However, I'm not getting the speckles like thing, right? So this is more straighter. I am getting a lot of speckles here because the pleura as well as the tissues under the pleura, which is lung tissue, are moving. However, here I'm getting almost straighter lines. This is because there is little to no movement here. So there is loss of movement. Hence, this looks something like a barcode. So this is called a barcode sign. Other name is stratosphere sign. Stratosphere, the layers of atmosphere, troposphere, stratosphere, etc. So this is the stratosphere sign or barcode sign seen in patients where there is little to no movement in the pleural cavity and below, in the pleura and below. So since we are able to see this finding in the left lung, so I would say that there is no movement in the left lung, no left lung sliding. So this is a classic feature of pneumothorax. Yeah. So seashore sign in right lung, which is normal. Barcode sign was seen in left lung because there was no movement, little to no movement. So this is classically seen in pneumothorax because pneumothorax just forms the increases the intrathoracic pressure. So while respiration, it won't even allow the lung to expand and even move. So this is the case of left pneumothorax. And in case of trauma, considering this could be open pneumothorax or tension pneumothorax, whatever, right? And another thing, this is the rib and this is the shadow, acoustic shadowing by the rib. Okay. Yeah. This is the image of this ultrasound video of the left lung. This is the probe marker you can see here, taken using linear probe. Yeah. Here, if you see carefully, let me play it again. What was the normal finding which you saw in the lungs? Lung sliding. What is the normal sign which you saw for the normal lung sliding? It was ants on a long slide, right? So here I'm unable to appreciate any of the ants on a log side here. So it's just moving as a whole. So like, let me mark it down. This whole segment is moving as a whole, right? However, in normal thing, you would just see the pleura just slide over each other. This is not the case here. So possibly there is reduced lung movement. And also we need to take M mode here. So if we take M mode here, we would get again the previous one, the barcode sign. So this is the case of left pneumothorax. Absent lung sliding in the left lung. So this is the left pneumothorax. I think that's the end of the application part. So thank you very much for everyone who are staying with me. Thanks. I was I'm happy to know that you are just here to give me company. So this is for your further learning. These were the resources I primarily used. So this was a YouTuber named Jason T. Nomura. He had a single video on the physics, the basics of ultrasound and the physics behind it. And also I used images from Radiopedia and learned about the steps from the Merck manual. And this was the literature which I used for other references purposes, which is ultrasonography examination by McGraw-Hill publications. Yeah. So finally, I am concluding this pictures and new masterclass series with three modules, namely chest X-ray, CT brain, and eFAST. So it has been a long run. I thoroughly enjoyed it, and I hope that you did too. You and I hope that you learned a lot of information regarding the basic interpretation for the UG level as well as for interns. So, and I can assure you that the knowledge which you gathered across the span of these three modules will be more than useful for your future. Fine. So that's it. Thank you very much. And in case I don't see you, good afternoon, good evening, and good night.